Dr. Duffy, this is Brittany.
Yeah, Brittany.
Is there a point in time where we'll be working directly with the practice advisors, like within the clinic?
Yes, that's going to start in November. And you will be getting to know the ones that you will be working with in your region toward the end of October. And then they'll start working in November.
Okay, thank you.
Okay. Any other questions?
Dr. Duffy, I think Ashley and Allie and I are pretty up and up with what the PAs do day to day. We've seen a lot of them in action, so.
Can you tell me?
Well, you rounded it up in a nutshell, really what they do. I mean, it is a lot of working with the EHRs to make sure that the facilities are getting the maximum use out of it and meeting their, meaningful use measures. So we've seen and have gotten to kind of dig into those EHRs ourselves, so it's kind of nice.
So you've done it too. You have a good sense of the EHRs that you're going to be working with. Is that right?
A little, yes. Yeah. There have been a few things that they've kind of allowed us to help with, but not full-on site visits on our own or anything like that. But we have a good idea.
That's good. Now, it's my understanding that since we're down the road in a lot of these EHRs, that a lot of the advice can actually be done at a distance. And it's a matter of working with the vendor to turn on some of the functionality that the practice may not have been aware of, as well as maximize the way the practice records into the EMR so that they get their outcome measures calculated properly. Is that right?
Yeah, you can. There's a lot of times that we'll be on the phone with vendors trying to troubleshoot some stuff, and sometimes they have to go, to a higher level of getting the access for the facilities, to, for those functionalities. But we've done WebExes with them too. So yeah, there's a lot of different avenues that you can take with it.
Fantastic. Any other comments? Okay, let's move on to the academic detailer. And I'm going to, first of all, tell you what the academic detailer is and what they do and why they're in this project. And then I'm going to give you a little bit of background and historical data about where these folks came from. So academic detailers, the name is pretty squirrely if you ask me, but detailer actually comes from the pharmaceutical representatives, or the drug reps or drug detailers. And back about 20 years ago, the people in Boston became concerned that a lot of the continuing education that physicians were getting was being provided by these pharmaceutical detailers, and they were providing a biased story. They obviously were helping the practitioner think about how good this particular drug is and prescribe that drug. The academic or the pharmaceutical detailers were paid based on how many sales their particular drug increased in the region. So some of the academics at Harvard and the Boston hospitals began to do a program in which they taught physicians how to go out and teach physicians in practice guidelines for care and processes for improving care. And thus the name academic detailer was born. And it's been demonstrated to be a really very effective way of helping a physician change the way they practice. So who are they? First of all, they're clinicians. They're either an MD, a DO, a physician's assistant, or an advanced practice registered nurse. And in our program, we're going to have some from each of these categories who will be our academic detailers. They're generally very interested in teaching. They love to tell their colleagues and peers what they're doing, what they've learned, and they're very effective at it. The second criteria is that they have been involved in some form of practice transformation. And the two that are big in Oklahoma are the Comprehensive Primary Care Initiative, which is run in the northeastern Oklahoma and around the Tulsa area. And there are 63 practices in the state who have been engaged for 2 years so far and still have another year to go in changing primary care to an advanced form of primary care. This particular project put care managers in the primary care offices to demonstrate how the care managers could actually improve the quality of care and reduce the cost of care by eliminating unnecessary hospitalizations or emergency department visits. We're going to hear the results of how that project has gone and find out whether there are going to be any shared savings from this particular project. The early word is there are substantial shared savings. In fact, I heard from one of the executives in one of the insurance companies that the savings are so great and the amount of money that's going to be paid out to these primary care practices is so much that the executive wanted a reanalysis of the data to make sure it was accurate, because nobody expected that the quality would improve as much as it did or that the costs would be saved. So this is a really big deal, and it's going to be one of the things that we are going to want to have the academic detailers talk about with practices, and one of the things that the PEs are going to know about. We've talked a bit about value-based purchasing and value-based payment, and this is one of those value-based payment models. The second project is the Oklahoma Practice Research Network, and I'll be giving you some of the background information on that in a minute. This is something that's been around for a while, and it's a group of practices that have joined together as a loose affiliated network to perform quality improvement research and activities. But as a result of it, practices who are in this PRN, actually have also been involved in practice transformation. The fourth part of the academic detailer training is training by the National Resource Center for Academic Detailing, called NARCAD, not a very good name at all, but NARCAD actually has come to Oklahoma and trained 20 of our academic detailers through role play and conducting a detailing visit and using a detailing handout that describes the guidelines for aspirin, blood pressure, cholesterol, and smoking cessation. So what is academic detailing? Functionally, it is peer-to-peer education, clinician-to-clinician education. It facilitates QI strategic planning, and it introduces the practice facilitators to the practice. Now, this is ideal that we do that. It turns out in the H2O project, most of our practice facilitators are already meeting their practices in the recruitment and enrollment phase. So actually, the practice academic detailer is going to come on the third visit with the practice or the second visit with the practice, not the first. Academic detailing is one of the multi-components of QI support strategy. This also includes feedback of those outcome reports, practice facilitation by Ps, IT support by the practice advisors, and facilitated cross-practice information exchange in that information network. You know this now, but H2O is the second federally funded grant to support the development of the primary healthcare extension system for the country. It has been funded by the Patient-Centered Outcome Research Institute, PCORI, and the Million Hearts Initiative through ARC. It's focused primarily on cardiovascular disease risk reduction, and the impact of this project could well determine the fate of future support for primary care quality improvement. So a lot is resting on this project. Academic detailing is one of the 4 support components that are going into this project. So what does the academic detailer do? They go in and answer questions for the practice about the project. They discuss the latest cardiovascular disease reduction guidelines. For instance, there will be 2 rounds of guidelines. One is aspirin and cholesterol, or statin use for people at high risk for coronary artery disease, mainly because they have high cholesterol. And the second one is controlling blood pressure, screening for smoking, and if people are found to be smokers, advise them to quit. The academic detailer will also discuss the clinical challenges and implementation principles and ideas that the practice might like to use to improve their cardiovascular disease risk reduction. The fourth thing that an academic detailer will do is help the practice select targets for their ABCSU, and the U is utilization measures, and that is the percent of hospitalizations in the practice and the rate of emergency department use. And then lastly, the academic detailers will introduce the P and discuss the P role with the practice, turning over the practice change activities to the practice assistant. So any questions now about what is an academic detailer? How are they selected? We ask a lot of physicians in Oklahoma if they would be interested. I think we invited 80 to participate and actually have had 25 take up the invitation and have demonstrated their willingness to do this job. Any other questions?
Dr. Duffy, this is Courtney.
Yeah.
So they will actually go in before we do?
Well, here's how it's going to work. There's going to be what we're calling the kickoff visit. And the kickoff visit will be an academic detailer and the P both in the practice at the same time. And you will both meet with everybody in the practice and with the physicians. And the academic detailer is, and we do that so that the practice knows both of you are working together to help this practice make its transformation. And the academic detailer will fundamentally turn the project over to the practice enhancement assistant, telling the practice that the detailer is available. The PEA may be contacting the academic detailer through telephone or text or email with questions that the practice has, or the practice can contact the academic detailer directly. The AD will be in the practice at the beginning of the year intervention, and then at the 6-month mark. There will be a second detailing visit at the 6-month mark when we shift from either blood pressure smoking to aspirin cholesterol goals. Does that make sense? Any other questions? What do you think about that, Courtney? That both being in the visit at the same time?
Oh, I don't have any concerns with that. I was just curious, just trying to get an idea of how everything's going to take place, when we're going to be stepping in, and so.
Yes, terrific. That's why we're doing these things, so that's really good. So how did we get to H2O? And this is a little bit of historical background. The Oklahoma Physician Resource Research, that's what the R's mean, network, OKPRN, www.okprn.org is the website, was founded in 1994. There are 246 clinician members in 145 practices, 165 MDs, 56 DOs, 21 PAs, and 21 advanced practice nurses. 226 are family medicine, 11 general internal medicine, 16 peds, and 23 are others, usually general practice. 48% of the practices are rural. They're mostly small with an average of 2.2 clinicians, and 95 peer-reviewed research publications have come out of this network. That is really, really an impressive productivity. So OKPRN started out as research done by practitioners in their practice. And that is an activity that has been very highly advanced in the family medicine field, and there's an entire group of physician research networks around the country. In 2001, the OKPRN began doing quality improvement research. And the purpose of this was to focus on improving the delivery of preventive services. And it also included best practice projects. So their idea was to identify among the practices in the network those that have the best practices, and then share those principles and techniques with everybody else in the network. They introduced performance feedback with and without benchmarking. Now let me make sure you all are on the same page with the definition of benchmarking. Performance feedback means that you take my performance measures on, say, the percent of patients who have ischemic heart disease, what percent of those patients are receiving aspirin. That number might be 50%, it might be 80%. And that's performance feedback. Now, benchmarking, and it says with or without benchmarking, benchmarking means you tell me what my rate is, 50%, and then you tell me what the highest rate of any practice is in our network. And that might well be 85%. So I now know that I'm at 50%, but somebody is at 85%. So at least I know it's possible to get to 85%. That gap between my 50 and the other's 85% is what I want to close. I want to bring that gap closed by bringing my 50% up as close to the 85% as I can. The value of benchmarking, it's so incredibly valuable, is that it identifies practices that are doing something right. And people like to go and visit those practices and find out just what are you doing? How are you able to do this? What we find out is that if a practice has a 50% performance rate on a measure, their practice system is perfectly designed to achieve a 50% performance. You got that? It's really amazing, but it is really true. That 50% performance is not a function of the clinician, how smart they are or how dumb they are. It's not a function of the nurses. It's not a function of anybody but the entire system. And the way the group works together, the way it applies its knowledge, and the way it works its workflow determines what that performance is. So when practices go to find a benchmarking practice, one that has high level of performance, they begin to look at what is in the system that's making that high level of performance. QI facilitation by the practice enhancement assistants, or PEAs, is another part of the Oklahoma PRN. So before H2O came along, the Oklahoma Practice Research and Resource Network had actually experimented with using practice enhancement assistants. And they copied the Canadian research model, used mainly Masters of Public Health graduates who were trained in primary care quality improvement. So with the introduction of the PEAs and the reassurance of the practices that they would be helpful and wouldn't interfere with patient flow, it really began to work. The practices found the PEAs very useful. Now let me emphasize this issue. We had to reassure the practices that the PEAs wouldn't be underfoot and the PEAs wouldn't be coming in and saying, you need to do this, doctor, implement this tool. But they actually helped the practice implement the tool and did a lot of the work that went into making that occur. They provided information about recommendations and implementation methods used by their peers, particularly the benchmarked peers. They developed guideline summaries and other clinical tools, such as algorithms, to help make decision making. And it was a they had a reconceptualization by facilitating agenda setting and actually doing quality improvement meetings. The most important thing that happened in the peer-to-peer meetings with the academic detailer and the practice was the demonstration of respect, that the practices, we're not coming in because the practices are doing a lousy job. We're coming into the practice because this is a practice that's doing a really good job, and their system could use some toning so that it does an even better job. What do PEAs do? Well, PEAs find and develop resources for practice change. And in your training right now, you're learning a lot of these resources. Last Wednesday on Linda's presentation from SUNY Buffalo, she talked about the use of the flow chart as a way to understand what the workflow is in the practice. PEAs used to do monthly chart audits, and they used that chart audit to give the practice feedback on quality performance reports. In the H2O project, we're going to use My Health, which will gather that data directly from the electronic record, and we won't have to do the tedious job of chart audits. We may have to do it from time to time for other reasons, but not for the feedback about the quality measures. The PEAs do staff training and encouragement. You'll probably be doing as much education and training as you will be doing anything else in this job. Our strategy is to have a PE in the practice on average a half day a week for 6 months initially, and now in the H2O project, we're extending that to a 12-month intervention. This is going to be probably the largest, longest intervention we've ever had in any of the research projects. The projects we do are research, and they have a HIPAA waiver, and they are approved by the Oklahoma I can't block, OUHSC, can't remember it. And there's a need for the, we think there's a need for the PEAs to be introduced by the academic detailers. Although I think in this project, we're going to find that's not going to be nearly as important. What's more important is demonstrating that it's a team of people helping the practice. So is there proof that this practice facilitation works? And the answer is absolutely. The Canadians did a meta-analysis of the published practice facilitation trials, and they demonstrate that it improves practice performance in a dose-response fashion. That means the more frequent, the more often, and the longer a practice facilitator is in a practice, the better the practice is in performing their outcomes. And most importantly, the practice facilitation is cost effective when the benefits of preventive services are considered. We've demonstrated in the Comprehensive Primary Care Initiative that actually putting people into practice who have quality improvement skills is really a very good way to improve cost effectiveness of the care. The practice facilitation method was adopted by the Institute for Healthcare Improvement, IHI, by TransferMed and others, and is being used around the country to transform primary care practices. And Jim Mold mentions that Jerry Avon and his colleagues at Boston conducted randomized controlled trials of academic detailing as an antidote to pharma detailing. And what they demonstrated was they could effectively change physicians' prescribing behavior. Pharmacists, nurses, and physicians have functioned as academic detailers. Any questions up to this point? Any comments? Now I'm going to tell you about a couple of grants that we've had in Oklahoma. We had the Impact Grant, and that was about 3 years ago. And it was granted, it was $1 million 2-year award in 4 states, Pennsylvania, North Carolina, New Mexico, and Oklahoma. You notice that North Carolina, New Mexico, and Oklahoma are all in the H2O project. So this is a small group of states that have been really focusing on this activity. The purpose of the Impact Grant was to establish certified county health improvement organizations, or CHIOs. And the CHIOs were certified by the Public Health Institute of Oklahoma. So this structure is a democratic structure that allows people to organize at the county level. There's no superior telling them what to do, no hierarchy or top-down orders. These organizations occur at the local county level to improve the health of the county. What the Public Health Institute of Oklahoma does is set the certification standards for a CHIO. And I'll show you what those standards are here in a minute. The Oklahoma Primary Healthcare Improvement Cooperative is the thing that H2O is being run by. And it's a organization within the Oklahoma Clinical and Translational Science Institute. What's really neat is the impact grant generated for the Oklahoma Primary Care Improvement Cooperative, money from the state legislature to actually develop this extension system. We had 200,000 3 years ago and down to 177,000 this year, and that goes a long way to helping build out this extension program. Here's what a CHIO looks like. You've seen this slide before, I think. It has patients on the CHIO, public health, mental health, education in the county, business, public safety, hospitals, primary care, social agencies. And they all sit around the table of the County Health Improvement Organization to develop the health improvement plan for the county and the health assessment for the county. Here's what it takes to be certified as a CHIO. It can be one or a few small contiguous counties. Most of them are one county, but there are several that are 2 or 3 counties. It's a 501c3 or it's affiliated with a 501c3. And the purpose for that, having a nonprofit status, is this is an organization that can apply for grants and can manage the money that comes through for project grants. Its mission is to improve the health of the population, that is the whole county. It involves public health, mental health, social services, local coalitions, hospitals, but most importantly, it brings primary care to the table. It brings the physicians to the table who have not often been a part of these county level health improvement organizations. There's a primary care advisory group for each CHIO. The CHIO endorses the county health improvement plan, and it has a process for strategic prioritization of the work that it wants to do. Here's where the CHIOs are located as of April 2015. You can see this, let's see, where is it? Well, here is one CHIO between LaFleur and Latimer County. It actually shows it as 2 CHIOs. That isn't quite accurate. So there are 21 CHIOs serving 25 counties. In the Affordable Care Act, the need for a primary care extension system was recognized for its importance of the relationships with local facilitators. And so in the Affordable Care Act is a blueprint that models after the Agriculture and Manufacturing Extension Program. And the Agency for Healthcare Research and Quality was assigned to develop the Primary Care Extension Center, but they had no funding. So nothing happened with it. And that's why we're so glad right now we are part of this project, which is going to test out the theory of whether or not a primary care extension center works. So here are the things we've talked about that are part of the H2O project and are part of a multi-element intervention for improving primary care. Performance feedback is the report of how we're doing on our measures. And the academic detailing is a teacher coming into the practice, working with the practice to find out what the practice needs and what they want to improve. The facilitator is somebody who gives a hand, helping the practice take the data from their performance feedback and change the practice. IT support is needed now because one of the major ways we make the changes is through technology and incorporating the EHR into the practice process. And lastly, practices get together in their local learning collaboratives to share best evidence, to benchmark the high-performing practices, and have everybody go and find out what are those high-performing practices doing to get the results they get. Okay, any questions about all of this? What is an academic detailer? What is a practice advisor? What is a PEA? And what is a primary healthcare extension system? Any comments? Any questions? Anybody still awake?
I'm still here. I don't have any questions. That was a really good presentation.
Okay. Does it make sense, Brittany?
It does. It does. Each time that you go over it more, it's just getting more embedded into my head exactly what it is we're doing.
Yeah, that's what I wondered. There are so many acronyms in this, and it's kind of confusing, and it's quite frankly brand new. Therefore, most of us haven't had any prior experience with this. Allie, Ashley, or Courtney, you guys have been doing this work for a while. What insights can you bring to what I've said?
This is Ashley. It was good to hear about academic detailing because we haven't worked with the academic detailer before. So it was good to see what their role is and how they will be helping us.
Now, you've worked as a P before, haven't you?
No, I have not.
Oh, you haven't. Okay. Have either Allie or Courtney, have you worked as a practice facilitator?
No, we have not.
Okay.
So basically, Ashley and I started with OFMQ in May, and we have been shadowing a lot of the PAs. I have had some hands-on work at some of the facilities, not anything major or just completely on my own. So this is all really kind of new for us as well.
Is the approach we're taking fairly consistent with the approach you all are taking?
Well, right now, everyone that we've been working with, the PAs have been working with for quite some time. So they're very familiar. We just go in and work with typically the office managers. Occasionally you'll have a physician that you get to work with, but they're usually pretty quick visits, just making sure that they're still on track with what they've been doing.
And what kinds of things are you helping the practices implement?
Mostly it's just meaningful use measures. Of course, we do the security risk assessments as well. We do some walkthroughs on those also, but that's a majority of it.
Okay, so it's pretty straightforward and narrowed focus in getting those meaningful use measures up and running. But aren't there 9 meaningful use measures that practices have to report?
Well, they have their CQMs, of course, that they have to report, but that ties into like PQRS and the meaningful use. And of course, I just kind of forget that we have been doing the Million Hearts and the Pediatric Cancer Registry as well. But those are typically pretty small visits, nothing too major with, too in detail with those.
So what are you doing on the Million Hearts? Have you been on any of those visits?
Yeah, we've been on a few of the visits, mostly running reports and just kind of educating them on things that they can do to, help with the hypertension mostly.
Right. And in the Million Hearts, you're helping the practices refer patients to a hypertension care coordinator. Is that right? Or is that a separate project?
I haven't seen any of that. Ashley, have you seen the other Ashley do any of that? Or Jimmy?
No, I haven't.
Okay. All right. Thank you. Any other comments?
I have one question. Will we be running any of the reports, or is that mostly the PA role?
Oh boy, that's a really, really good question. So you won't, how do I want to put this? You won't be necessarily running reports out of the EMR unless the practice wants to now work on things that are outside of the ABCSs. So if they've done their ABCSs and got a high scores and they're done, they're going to sustain those gains, then they may want to work on something else. In that case, you'll then need to go into the EMR and have other reports printed. What you're going to get, and you're going to get training in a couple weeks on a tool called Tableau. That's Tableau. And Tableau is a data analytics tool that comes with My Health. And it's a web-based tool. You go onto it and you're into a secure website where the practice's data is now in what they call a sandbox, and you can manipulate that data to generate reports. And you're going to learn how to do that and actually how to teach the practice how to use Tableau to generate their reports out of My Health. And I think you're going to find that to be a lot of fun. You will generate those reports and generate dashboards, a quality improvement dashboard that has multiple measures for the practice and multiple characteristics of the practice. Any questions about that, or does that make sense to you? Okay, moving on. Let me ask you, did we review this with you, this slide?
I have seen it.
Who is that? Brittany?
I've seen it.
Okay, yeah, Brittany, did I go over this with you? I think so, right?
Yes, you did.
Okay, how about the others? Ashley, Allie, Courtney? Courtney?
This is Courtney. I think I've seen it on the first call I was on.
Yes,
Okay, you guys have seen it as well. I wasn't sure whether we had done that or not. So this is the model that I like to use to describe a practice, and we call that a clinical microsystem. Every practice has a purpose. It's to deliver high quality care for patients. Every practice has patients who come into the practice and leave the practice hopefully better. Every practice has professionals who work together within the practice to deliver the care that the patients receive. And every practice has practice processes. So the work is actually divided up into steps or stages in which people work together. Like this might well be the rooming, maybe this is the check-in step. This might be the rooming step that the MA does. This might be the doctoring step, the history and physical and planning the lab. This might be the step if the person has a chronic disease, doing chronic care management and follow-up. This could be an acute step in which prescriptions are given. This could be a preventive medicine step, and so on. The symbols here mean that we measure the patterns of the practice, and we measure the outcomes of the practice. What are the clinical outcomes? What are the patient satisfaction outcomes? What are the financial outcomes for the particular practice? So by looking at this model of the clinical microsystem, we can begin to look at the things that we might change. And remember, I'm going to say it again, that every microsystem is perfectly designed to get the outcomes, the measures that it gets. And so if you want to get different measures, what we need to do is change something or several things in this deal. Now, the things we change are, we might change the professional roles and responsibilities. We might increase the amount of independence and flexibility that medical assistants have by implementing a standing order. We might change our work processes, eliminate waste in the work processes, improve the efficiency of the work processes. We can't usually do very much about the patients that we have, but we can, through several of our processes, improve the patient activation and engagement in their care, and that improves the outcomes as well. So that's kind of a high-level deal to describe what we will do. The microsystem improvement process that we're teaching in this particular course is the DEMIAC model, where we define the problem and we define, are we achieving our purpose? Are we meeting our patients' needs? And we will mainly define the problem for the practice by looking at what their ABCS performance is. And that's how we'll start with the definition. So when the academic detailer and the P come in for the first kickoff visit, it's our expectation that they are going to actually have the quality dashboard available for the practice. And that quality dashboard will show them where their baseline aspirin, blood pressure, cholesterol, and smoking rates are located. In addition to that, it'll give them an idea of what kind of quality improvement infrastructure they have in the practice. It'll give them an idea, something about the patient, the staff satisfaction with the way the practice is operating. It'll tell them a little bit about the characteristics of the patients that they have. And out of that information, the academic detailer and the P will review the dashboard with the practice and help the practice define some targets that they want to achieve. And there are 4 goals, and I think we talked about this the last time we talked. There are 4 broad areas of goals that the practice might be interested in. One is they have to improve their ABCSs. The second thing they may want to do is improve their financial viability. And they can do that through meaningful use, through improving their transitions of care. They may wish to improve the joy in practice. If they have a culture or an environment in the practice that's not very conducive to a joyful practice, there are things we can do to help them overcome that. And then lastly, we want them to have their practice engaged in developing a healthy community. And they'll do that by working with their CHIO in the county. So that first kickoff visit is all about defining the opportunities that the practice has for improvement. Let me stop and ask you about your experience in doing anything like that with practices in the past. Brittany, do you want to chime in?
I'm sorry, repeat that? So do you want to chime in?
Yeah, so have you actually helped a practice define their opportunities for improvement by having them look at their system of care?
You mean with this project or in general with my...
Anything you've ever done before, any of your MPH work or other work?
Yes, I did. I helped a Planned Parenthood clinic in Ithaca, New York with their patient flow. And over time, by rearranging some of their stations and the way that they have their process, we helped improve their patient flow pretty drastically.
So you worked in this area, and how did that go?
It was rough at first, but once we got their buy-in and they saw the improvements as we went along, they were glad they changed it.
Fantastic. Now, the question I'm asking you now is, when you started that process, did you start by defining the opportunities for improvement that that Planned Parenthood clinic had?
Yeah, so they were changing facilities. They were in the process of moving to a different building, so it was easier to define the problems then at the beginning.
Good, and you saw lots of opportunities to fix some things that were in the old facility that they didn't need to have in the new, is that right?
Correct.
Yeah, great. Okay, so Courtney, how about you? Have you done any of this before?
No, sir, I have not.
Have not. Have you ever helped a practice define what their opportunities for improvement are?
Nope, sure haven't.
Okay, well, you're going to have fun. You're going to have a lot of fun. Ashley, how about you?
Have not.
You've not either. Now, in the practice shadowing that you've done, have you seen this done?
And with meaningful use, a lot of times we have to figure out a new process, for instance, to get patients to sign up for the patient portal and get logged on. So we have to come up with a process to get their email and get some incentive for them to log on.
So
that's one process I've seen.
Okay, so that is that meaningful use of getting a patient portal up and running, communicating the results to patients. Is that right?
Correct.
Aha, great. Okay. Well, the second step in the DMAIC is measure. And this is one of the things that PEAs have done always in these projects, but it usually was they went in and did it they did the chart reviews. And what we're going to do here is we're going to have measures of the patient characteristics, and we're getting that in the practice survey. We're going to have measures of the process. You've already learned how to draw a flow chart of practice processes, and the flow chart is a measure of the practice processes. We measure the professionals, the satisfaction, the attitudes of the professionals, and we'll be getting that in the practice member survey. And then we also have the outcomes, those ABCSs and the utilization measures of the patients. So we take all of those measures, and once we've defined the opportunities for improvement, we look at the measures, and we may take additional measures to find out where the practice stands. At that point, we analyze the measures, and analysis here fundamentally means we do a root cause analysis. Why do we have the outcomes that we have? Why? And we ask why 5 times. Why is it there? Well, why is that there? Okay, that's one reason. Why is that reason there? And we analyze it till we get to the root cause, and our goal is to actually improve the root cause, change the root cause. And we do that by coming up with interventions that we plan to apply it in a small segment of the practice. We make the change, see what happens, study it, and then make a decision. We act on it. What are we going to do? If it really works, we then control or keep the gains we've made in the improvement by standardizing the processes, and you did that in several of the projects you've been on, training the staff and providers, measuring the performance, and rewarding high performance. Rewarding high performance. So this is the P and academic detailer stage. This step, and this step, all of these and this step are the job of the practice enhancement assistant. And you'll be going through each of these steps, spending probably most of your time on the improvement step, doing repeated PDSA cycles. And once you have something that works, get it implemented to keep the gains that you've made. So let me stop at this point and ask you, does this conceptualization help you get a handle on what you're doing at a high level? I'm sure it doesn't tell you exactly how to do it, but does it get you an idea of what you'll be doing?
Yeah, Dr. Duffy, this is Courtney. I think the more that we're, on these calls and we're going over this stuff, it's becoming a lot more clear as to, what direction we're going to be going with it.
Great, great. Yeah, these are going to be where over the next month you're going to be learning how to do this. And then this you'll be working on for the next 18 months, changing over and over. And the calls that we have where we talk about what has worked in one practice, and it will really create a huge amount of knowledge that we'll share with each other. Brittany, were you going to say something?
Basically what Courtney has said, I just agree. The more and more that we go over this type of thing, the more that I'm understanding what we're going to be doing.
Okay, terrific. All right, so what do we do in an academic detailing visit? I think we've talked about practice recruitment. In fact, I know we have. And I know we've begun to talk about we did last Thursday. We had a session on, or was it Wednesday? We had a session on, I guess it was Thursday. We had a session on the enrollment visit. So now we're into the third visit. In fact, I may have this out of line here. Yeah. So here's the practice facilitation process. Stage one is recruitment and assessing readiness. And we've talked about those two steps in prior weeks. You're actively involved in the recruitment right now, and we're going to begin assessing readiness next week. We're going to actually begin to schedule some of the enrollment visits where we're going to assess and measure the readiness of the practice to change. Then we'll schedule a visit, a kickoff visit in November, where the academic detailer and the practice enhancement assistant will meet with the practice. In that visit, they will begin to do some goal setting, look at the quality dashboard and do some goal setting, and then the PEs are off and running to do the remaining steps over and over and over again over the next year. So let's look a bit at what that will happen during that detailing visit. Ideally, the detailing visit will occur with at least the clinicians, and ideally the clinicians, the office manager, and some of the other staff. Introductions will be made. The academic detailer will introduce him or herself and the practice enhancement assistant. We ask about how much time do we have. We want to schedule these visits for about 45 minutes, but practices, as you're beginning to learn already, you never know how much time they're actually going to have. We then answer questions about the H2O project, and we will have a handout that will be simple, easy to understand, describing the H2O project. And then the academic detailer will discuss the new clinical recommendations and guidelines. They will either discuss the aspirin and statin guidelines, or they'll discuss the blood pressure and smoking. And remember, I told you the other day that which one they pick will be randomly assigned by the researchers. They will then discuss a little bit about the current processes and good ideas that have occurred from other QI concepts. That discussion will be generated by the quality dashboard. They will then agree on a plan for improvement, and they will take questions from the practice facilitator and schedule the next facilitator visit. So this is really a visit that gets us off and running, kicks off the quality improvement activity that's going to be done, and pretty much sets the beginnings of a plan for improvement, identifying the opportunities for improvement, not really identifying exactly what's going to be done to make that improvement. How many visits are we going to have? So right now we have recruitment if we divide the year intervention into 2 6-month phase, recruitment is going on now, and the Ps are actively involved in the recruitment. You're now getting some help from the academic detailers, and they will be increasing their input on recruitment in the next several weeks. The P will then have a visit with the practice alone in the first 6 months to assess the readiness of the practice. And the IT practice advisor will also have a role in assessing the practice readiness. They're mainly going to be looking at the EHR to make sure the EHR is one that we know is able to be up and running. Then we have the kickoff meeting, which will occur once in the first 6 months and once in the second 6 months. The P will do 2 of those, one in the first and one in the second, and the academic detailer will do 2. There will be about 4 visits, I would estimate, in the beginning on assessment and goal setting, and about 2 in the second go round. So the P will have about 6 visits will be focused on the assessment and goal setting, and then about 15 visits on active facilitation, 2 visits on holding the gains, and 1 visit on completion. Now, is this the way it's going to work out regularly? I doubt it. It's just a schematic, an overview to get an idea of where are we going to be spending our time. You can see that we have in here about 32 P visits, 2 academic detailer visits, and I've shown 2 IT visits with some telephone calls that aren't shown on here. Well, I think our summary here is that the H2O project aims to build practice capacity focused on the ABCSs. Practice capacity in systems-based practice and practice-based learning and improvement. Facilitators need anatomy of the practice, knowing the clinical microsystem, and learning the DMIAC change process. And again, the practice facilitation process begins by taking the practice vital signs, which is that baseline assessment. So in one way, the way we're looking at this is that enrollment visit that the P will do is kind of like the rooming visit that the nurse or medical assistant does by going in the room and taking the patient's vital signs. And then the physician comes in for that kickoff visit to make the diagnosis and plan of treatment. Well, that's plenty. My voice is gone.